Welcome, everyone. Good morning, good afternoon, good evening, or small hours of the morning. I'm Henrietta Fore, Executive Director of UNICEF. All of us at UNICEF celebrate the determination of people who overcome barriers, who achieve great personal and professional goals, and who advocate for the rights in the fight against HIV. Mothers, we see this determination in your eyes as you access PMTCT to protect your children from HIV. Children, our hearts leap with joy as we see you healthy and we imagine a future for you that is not defined by HIV. And adolescents, we see this spirit in you as you support one another not only through HIV but through life. And providers, government officials, and advocates, we see this determination come alive in the actions you take and investments you make in children's futures. Over the past 40 years, we have seen one of the most extraordinary public health responses in history, and we've seen how innovations combined with political will and investment have made all the difference. Today's session is all about exploring innovations that use technology to diagnose multiple diseases, to improve data collection and use by decision makers, and to close programmatic gaps. After the presentations, there will be a short Q&A panel discussion with speakers. So please type in any questions you have about how we can use innovation to make health systems stronger for mothers, children, and young people. Once again, thank you for joining us and for all the work that you do. If we are to improve treatment access, we must also improve pediatric testing and identify innovations to improve the efficiency and effectiveness of diagnostic technologies. This technology offers the ability to rapidly diagnose HIV in infants. It can also measure HIV viral load, and it can detect the presence of TB or diagnose HPV, the cause of cervical cancer, using a testing platform that is simple enough for providers to use at the point of care. Recently, these same testing platforms have been used for the diagnosis of SARS-CoV-2 and the virus that caused COVID-19. In addition to improving linkage to care, this point-of-care technology can save costs and offer a set of diagnostic options that were once unimaginable.
Hello everyone, and welcome to the satellite session. My name is Alex Costa, and I work for the HIV section at UNICEF headquarters in New York, where I lead the diagnostics work. The big picture perspective of multi-disease diagnostics is that it shows a significant impact on 3 levels: technology and innovations, clinical care, and health system strengthening. The technology used for multi-disease diagnostics offers the opportunity to test for several diseases, but it can also improve the level of preparedness for outbreaks such as COVID-19. This is the stage for presentations by our guests today. We're going to start with Aaron Mdolo from UNICEF Malawi, followed by our colleagues in the Ministry of Health in Malawi, Brown Chimwandila and Dr. Kusani Mbendera. And we're going to close with remarks by Unitage given by Smilka Delusini. The information that they're going to present here is based on a multi-partner project that has been funded by Unitage and implemented by CHAI, ASLM, EGPAF, and UNICEF. I hope you enjoy it.
Accessing diagnostics services in Malawi has been a challenge for a long time. A long turnaround time, poor sample transportation system. These have been around for a very long time. Turnaround time can go up to over 1 month, which is not good. Timely testing and clinical decision is very, very critical to ensure good patient outcomes, not only for HIV, but even other diseases such as TB, HPV, and viral hepatitis. The coming in of multiplex disease testing equipment is very timely because it has helped us to fasten the diagnosis of these diseases. And the coming in of this technology was not only the technological part, but it meant different disease-specific programs come together to talk and collaborate. This is the task at hand. Working together, we have demonstrated that when all these diseases are tested using the same equipment, there's no negative impact to any of these programs. With me here are two colleagues from the Ministry of Health who wants to share our experience on how this worked in Malawi.
The HIV treatment program in the Ministry of Health in Malawi for some time in the recent years was dogged by a serious challenge in its early infant diagnosis program, which was a long turnaround time of results. Remember, EID is very crucial. Early infant diagnosis is very crucial because if we don't take action timely on kids that are born with HIV or maybe that get infected quite early, you are likely to lose up to 30% of them before their first birthday and up to 50% of them before their second birthday. So it was really that big problem to have results only getting back after so many months until we took a pilot, which was to integrate EID testing and viral testing as well on our GeneXpert platforms. So integrating TB testing, which is already happening on GeneXpert with HIV samples, that's namely EID and viral load. We saw a significant improvement in TAT with the integration pilot. And even in data, we saw a 24% jump in pediatric enrollments of kids that are studying HIV treatment with a positive DNA PCR test result. The improvement was quite remarkable with the integration model. And we've moved on to even accommodate a lot more samples, so viral load for HIV and even HPV for diagnosis of cervical cancer is also starting to happen on our GeneXpert platforms. Moving forward, we look at a future of serious cost savings, efficient integration with use of this multiplex technology called GeneXpert to test multiple types of samples and getting results to patients on time.
As I was discussing diagnostic integration with Dr. Kuzani from the TB program in Malawi, there are a number of considerations to prepare the health systems of a country to integrate diagnostics, such as human resources, supply chain, biosafety issues, and waste management. But there is not enough time to talk about all of them. A very important point to consider is to make sure the inclusion of other tests does not overwhelm the capacity of the equipment. Disease-specific departments must also discuss cost sharing and ownership of equipment to avoid any negative impact on the maintenance and repairs. In our case, the decision to integrate tests have put the equipment to good use, and it did not impact our TB results. In addition, we estimated that multi-disease testing resulted in almost $20,000 of savings for the TB program. Usually, the same patient may need different disease sepsis, and integrating tests is a solution which allows for a patient-centered approach. For example, when a woman comes with an HIV-exposed child for EID, in addition to checking the HIV viral load, she can also be screened for TB and HPV. Because cervical cancer is the latest test integrated, I would like to finish giving you some numbers. By March this year, we had done 2,500 HPV tests, which were not easily available for patients before. These are important results only possible by our disease testing effort. Thank you.
Ulondo odiri ndwaorali mwina timachoka kuno kuti kakhakutalawira kwambiri tikaenda pasi timachoka pasi chifiri pamakwana 8 kuluku timakhala tikutani tikuyandikira kumene kuja kuyenda pasi.
usiku kugona mutu wanga sumagwira tusiti mabwera. Ndimakhala ndi nkhawa nthawi ndi nthawi ndipo ndinawonda kwambiri chifukwa chokuti moyo wanga nali sanachivomereze chinthucho.
Ndinadziwa ndili ndi zaka 11. Poyambirira ndimaona ngati ndimathera moyo wanga, ndilandira uphungu ndinena zoti zimathera moyo wanga ndi chiyambi cha moyo wina.
Ine amunanga nditapezeka HIV positive, nditawauza nonso anapita kukayezetsa, iwo anadzapezeka negative. Komano chilimbikitso chawo amangondilimbikitsa kuti iwe uzimwa mankhwala mwa ndondomeko mmene akuzira ku chipatala.
Mtemanga ndinamba kulumba kumana ndikhazika pasi kuti niyo mtemano usathamange ndithu umene ndi moyo woyenera kuti mtemano ukhale uthamanga mwana Yesu akhoza kuyamwira chani, akhoza kuyamwira kachilombo ndiponso akhoza kuyamwira mkaka woyipa. Kenako mtemanga namba kukhala pasi nadza kuti andi chitetezo choyenera chifukwa ndabwera ku chipatala kuno kundipatsa mankhwala.
Ineyo ndikungolimbikitsanso azimayi ena amene sanapitepo ku chipatala ndi kukayezetsa magazi kuti akuyenera kutenga mbali kukayezetsa magazi ndi kudziwa za mthupi mwawo ngati ayembekezera kuti akapezeka kuti ali HIV positive ayambepo mankhwala kuti amuteteze mwana amene akumuyembekezera komanso iwo akhale wa moyo wathanzi, moyo osadwaladwala ndi moyo wautali.
Ndimapangira zona kuti ana m'Malawi azakhala atsogolola bwino ngati mwina kumamwitsa bwino mankhwala cholinga azakhala ndi moyo wathanzi wautali bwino komanso azakhala wongodziletsa wopewa.
There are over 1 million people living with HIV in Malawi. We have a prevalence rate of 131 per 100,000 for TB and an incident rate of 73 per 100,000 for cervical cancer. And our data shows that 70% of patients with cervical cancer have perished. Note that almost all of cervical cancer death can be avoided when timely screening is available to all. We know now that we don't have to design our national response to control these diseases separately. And this is the biggest learning of all. For instance, at the same point, an infant exposed to HIV will be tested for EID, an older man with TB symptoms would be tested for MDR, TB, a woman would be tested for HPV, and anyone with flu-like symptoms could be tested for COVID-19. And the results are delivered immediately. A joint and interdependent national plan with mass disease testing is possible. We can pool funds together to keep diagnostic services available when priorities change. And we have seen that with COVID-19. It is not simple, but it can be done. As my colleagues from MOH mentioned, with these innovations, we were able to reduce costs and use our diagnostic capacity optimally. This means we service more communities, have better data, and can advance the Malawi health systems in the global health agenda.
The significance of strong and functional diagnostic networks has over the years been proven to be critical for any disease response. We all remember in the tuberculosis response how important it was to introduce molecular testing. In the HIV, we shifted from using clinical symptoms and immunological status of a person to actually measure the viral load in the blood using molecular diagnostics in order to assess whether the treatment actually works. And today, in the context of the health emergency response, everything that we have been investing for years in building those systems have already actually helped us to effectively respond to COVID-19, especially in Africa. The technology evolution itself has also been incredible. Today we can use the same platform or a device to actually test for different diseases. And this both at the central level or in the decentralized way, for example, in a district hospital, which means that we can organize the system as such to respond to the individual needs of a person who actually faces issues and faces different diseases. As UNITAID, we have been incredibly proud to collaborate with the government Malawi in generating the evidence on these innovations together with UNICEF and CHAI, especially because the evidence coming from Malawi has actually informed global discussions around political considerations or funding considerations, and especially technical consideration of what integration actually means, how it can be done, and to what extent it is beneficial and feasible for a response to any disease. Today, especially in the COVID-19 times, we as UNITED remain committed to pursue the integration principle, and it has been, as I said, at the forefront of the COVID response, and we need to support the scale-up of integration approaches, and I believe that many lessons learned will again come from Malawi, who continues to be our partner on this journey.
In spite of many systems that consistently engage parents and children, we are missing an opportunity to screen, diagnose, and link HIV-infected children to the care they need. Compared across all populations, children and adolescents living with HIV have among the lowest rates of HIV treatment. For infants born with HIV, this is critical. When left untreated, 50% will die before their second birthday and 75% before their fifth birthday. As children enter adolescence and young adulthood, untreated HIV infection has not only personal health implications, but the critical impact on HIV prevention as well. The following presentation will look at exciting and catalytic innovations to address these barriers to care and to accelerate access to HIV treatment for children and adolescents.
Good morning, good afternoon, good evening, esteemed colleagues around the globe. My name is Dr. Nande Puta. I work with the HIV and child health teams leading pediatric HIV in UNICEF New York, and I'm pleased to be facilitating this session along with my colleague from Ghana Health Services. Access to treatment for children and adolescents significantly lags other HIV program responses, such as prevention of mother-to-child transmission and male circumcision, where program scale-up has seen success in many locations. A myriad of challenges and complexities present barriers to efforts by national programs. Some of these include stigma, discrimination, family disclosure issues, consent challenges, and criminalizing laws. Today, we hear how Ghana, over the last 2 years, have taken very intentional and innovative steps to address these barriers. Ghana will take us through how they as a country took bold steps to address a low and stagnated HIV treatment coverage for children and adolescents, especially for marginalized and underserved children, such as those heading their own households as well as key populations. Over to you, Dr. Stephen.
Good morning, good afternoon, good evening, fellow participants on this virtual International AIDS Conference 2020. My name is Dr. Stephen Isiado, the Program Manager for the National AIDS Control Program. It's my pleasure to share with you under the theme Building Resilience in Pediatric HIV Cascade of Care, the role of index testing and peer support. My country has a low pediatric coverage, as has been shown in this next slide. The highest we've been able to achieve is 23% in 2017, with 83% of children living with HIV in Ghana being perinatally infected and a significant proportion missing the opportunity for early infant diagnosis. The introduction of family-based index testing was a game changer to help reach these infected, undiagnosed children. Over a 1-year period, 1,161 infected children and adolescents were identified through family-based index testing, and this moved our treatment coverage from estimated children and adolescents marginally from 22% in 2018 to 26% in 2019, due to the significant positive impact on testing yield. As you can see in the next slide, you notice a change in even linkage rates from 37% to 93% under F-BIT. There were cultural and economic barriers, however, to pediatric adolescent care, despite all the improvements in youth and initiation rates. And significantly, this was as a result of the fact that some of these children were double orphans, about 12%, and living with other relatives who don't monitor their clinics, visits, and medication intake. Some of them had parents who were sick, and therefore they were the breadwinners and did not have time to go for medications. Some of them became non-adherent once they left parental care to boarding school and hostels, and some of them were not aware of their status at all. In addition, due to the country's oil find and other pockets of development in regions, mature minors, especially females, took advantage of resultant economic opportunities, causing some to be sexually exploited and then getting infected with HIV and STI in the process. The abuse of pericoital oral contraceptives and stigma surrounding access to condoms further increase the risk of new infections in this population, as shown by the slide. The next slide is on deaths related to HIV among adolescents. You can see an increasing trend in deaths, plateauing from 2018 to 2019. So we put in some interventions and differentiated care for adolescents and children living with HIV through a conference which was jointly held by WHO and UNICEF in Dakar in March 2019. We got in contact with Jandiri Africate, an organization in Zimbabwe involved in differentiated peer support model of care for children, young adults living with HIV. The model uses community adolescent treatment supporters who are HIV positive young persons, stable on treatment, have family support, and have no significant psychosocial challenges to offer peer support to persons up to 24 years living with HIV. This is done during clinic visits, home visits, support group meetings, and remotely through SMS and phone calls. The technical support from Africa Jandiri and funding from Global Fund intervention is currently being piloted in 16 CATs in 5 facilities within 2 regions in Ghana since December 2019. Following the pilot, the CATs help provide psychosocial support to their beneficiaries and help reach very vulnerable groups within their target age. Through the support, a specific disclosure of HIV has been provided to all those who are eligible. According to country guidelines, 63% of the 126 beneficiaries who had psychosocial challenges at enrollment had their issues addressed within 3 months with mental health counseling and appropriate referrals. The orphan beneficiaries and those in childhood homes were linked to social welfare. Discussion sessions during support group meetings had helped empower these young ones to understand their own sexuality and appreciate modes of HIV transmission. Key populations who are very difficult to read due to Ghana's legal and cultural context are identified by 2 of the CATs who were incidentally part of the program, one of them FSWs and one of them MSM, and they have been offering support and hearing support to their colleagues within their networks. The beneficiaries in school who usually miss doses are also benefiting from peer support and counseling during designated visit days and through phone calls. The only challenge is their unwillingness to be visited in school. The impact of the intervention on the number of missed classes and unplanned home visits due to illness is yet to be documented due to the short implementation period and coronavirus pandemic. It is clear that these interventions have yielded great results, with a significant 97%, as shown on the slide, of newly initiated beneficiaries who were supported by the CATs who got initiated on ARVs were still in care 3 months after they were enrolled. This was very high, 97, compared to the 84% of persons up to 24 years in the pilot facility prior to the intervention. Again, the 23 AIDS-related mortalities in Q1 2019 in implementing facilities among PLs up to 24 years reduced to 4 in Q1 2020. Though not all the children and young persons living with HIV in these settings have been reached with the intervention. In conclusion, ladies and gentlemen, we see promise in taking a differentiated approach to address the varying needs of children and adolescents, particularly those who are vulnerable or marginalized. Combination of family-based index testing, community adolescent treatment support, mental health counseling, and linkage to social welfare is contributing to improving access along the cascade of care for HIV-infected children and young persons by getting them diagnosed early, initiating majority in care, retaining them, and providing for their psychosocial needs. Implementing these interventions to scale will therefore help to improve the treatment outcomes of these children and young people. We have therefore prioritized this for scale up under the Global Fund NFM3 application for 2021 to 2023. I wish to thank you all for your audience.
In the previous presentation, we learned that HIV testing is an entry point for treatment for children and adolescents living with HIV. We must constantly challenge our assumptions and look for innovations to support the data we use for decisions about program priorities. One of the major barriers we face is understanding the HIV epidemic for adolescents and how very local and specific factors fuel the epidemic among young people. The following presentation explores a new approach to use innovative data sources like mobile phone data to better understand HIV risk in adolescent populations so we can target our programming.
Hello everyone, this is Sudha Balakrishnan from UNICEF, New York. Joining me are Dr. Kome Konan Blaise from the Ministry of Health and Public Hygiene, Government of Cote d'Ivoire, Joseph Crispel from the Office for National Statistics, UK, Alex Hutchison from the Data for Children Collaborative with UNICEF, Edinburgh, UK, and Albert King from the Scottish Government. In this segment, we will talk about the use of new data and novel analytics for targeting subnational areas for adolescent HIV programming. In 2018 alone, 500,000 adolescents and young people in the age group 10 to 24 were newly infected with HIV. Two major bottlenecks limit design and delivery of effective services for this population. The first bottleneck is, where are the subnational areas where HIV risk and broader vulnerabilities for young people cluster? And the second, how do we find the young people at risk in these areas? Traditional data sources and analytics alone have been insufficient to solve these bottlenecks, and we need novel ways to address them.
En 2019, nous avons enregistré 12 187 nouvelles infections, dont 2819 au sein de la population jeunes et adolescents de 15 à 24 ans, ce qui représente 23% de ces nouvelles infections. Par ailleurs, nous avons noté que 83% des nouvelles infections de cette tranche d'âge sont observées chez les adolescentes et jeunes filles qui supportent de façon disproportionnée le poids de la maladie. Nous utilisons des données issues de plusieurs sources, à savoir les projections de spectrum, les enquêtes de surveillance du VIH, telles que les IBBS, CIFIA, l'EDS, les MIX, les données de routine des programmes ainsi que les données démographiques. Il est essentiel d'avoir des données sur les déterminants du VIH, y compris les facteurs de vulnérabilité au niveau des districts et des aires sanitaires. Au nombre des défis dans la prévention du VIH chez les adolescents et jeunes, il faut noter les estimations. Ces estimations existant au niveau des districts sanitaires concernent généralement la population dans son ensemble. Elles ne sont pas suffisamment désagrégées pour prendre en compte les adolescents et jeunes. Il faut aussi noter les insuffisances dans la cartographie des facteurs de vulnérabilité chez les adolescents et jeunes au niveau des districts et des aires sanitaires. Il faut noter qu'entre deux enquêtes d'impact telles que les EDS et les MIX, qui se déroulent généralement tous les 5 ans, il n'existe pas de données pour le suivi des facteurs de vulnérabilité des adolescents et jeunes. À cet effet, le projet Data Collaborative vient à bon escient pour soutenir les innovations en matière de données chez les adolescents et jeunes en Côte d'Ivoire.
Hi everyone, I'm Joseph Crispell, a data scientist working in the UK Government's Department for International Development. I've joined the collaborative to provide support on the data analysis and modelling branch of the project. As Sudha and Dr. Blaise have highlighted, the key issue we're planning on addressing is the prioritisation of HIV interventions towards adolescents at risk at the subnational scale. We're going to build upon the existing extensive HIV surveying and modelling initiatives. We plan to use novel data sources such as mobile phone data to augment these existing approaches and create a tool that focuses on risk in adolescents at the subnational scale. We'll also exploit the wealth of open data sources available describing the population and infrastructure in Côte d'Ivoire. As we know, there are a variety of survey data available for Côte d'Ivoire. The THEA and mixed surveys capture HIV prevalence and important risk factors from thousands of households, providing a geotagged snapshot of the HIV situation in Côte d'Ivoire and an important standardised means of evaluating progress at the national scale. Partner facilities within the PEPFAR HIV Indicator Monitoring Scheme provide quarterly indicators of HIV and a means by which we can capture trends. Mobile phone data provides an unprecedentedly high-resolution picture of the population, mobility and connectivity. There's been some really encouraging previous work that has explored how the patterns of HIV prevalence captured in household surveys are associated with population patterns of mobility and connectivity. By extracting features from the mobile phone data, capturing information like how often people move from one area of Côte d'Ivoire to another, this previous research demonstrated strong links between population mobility and connectivity with patterns of HIV prevalence across Côte d'Ivoire. There's a wealth of open data available for Côte d'Ivoire. Here are just 3 examples. The Facebook Data for Good initiative analysed satellite images to identify houses and estimate population densities at a high resolution across Côte d'Ivoire. The World Health Organization has published the locations of health facilities across sub-Saharan Africa, providing a means by which we can capture access to healthcare. And UNICEF are gathering a wealth of data through the U-Report initiative that will provide valuable information about potential risk factors. Other initiatives, such as the OpenStreetMaps project, will provide additional data on healthcare access through crowdsourced healthcare mapping projects and also provide maps of transport networks. So our aim is to feed these data sources into a modelling framework. We'll extract measures of prevalence from HIV household surveys, as well as a wealth of information about risk factors. We'll augment these risk factors with features describing the Côte d'Ivoire population and infrastructure, gleaned from these open data sources and big data sets like mobile phone data. We're going to use 2 modelling teams to construct geospatial models of HIV risk in adolescents at the subnational scale. At DFID, our team of data scientists will employ our expertise in the use of machine learning approaches. And at the University of Edinburgh, a team will draw upon their track record to implement a range of traditional modelling approaches. We'll evaluate each of the models coming out of the modelling streams to select a single or ensemble of models for building our tool. We'll then work to create a tool that, given updated risk factors, we can accurately predict HIV risk in adolescents at the subnational scale. Such a tool will rely upon the careful selection of risk factors that are readily available, as we hope to be able to bridge the gap between HIV surveys. So what I want to highlight here is that we are very much in the planning and exploratory phase of our project. We're excited to be working with such a diverse range of teams, and we're looking forward to hearing more about people that we can work with and new approaches that we should explore. So I thought I'd end on some key considerations that we have currently in our exploration phase of the project. So what are the most up-to-date and relevant approaches that we should consider? As we explore potential sources of risk factors, we need to think about how available they are. We're looking for risk factors that we can gather new data on regularly. Representativeness is also a critical consideration. Sampling and reporting biases are common with the types of data that we are exploring, and we need to think about how we can identify and account for these in our analyses. Lastly, we've talked a lot about prevalence. Can we move to measuring incidence, being able to quickly identify new areas with adolescents at risk? And we'll continue to think about these considerations as we move to build our tool that will hopefully identify adolescents at risk at the subnational scale. So I'll finish there, and I'll now pass to Alex, who will provide more detail on the inner workings of our collaborative.
Thanks to Joe for that really clear explanation of the variety of data and the data science involved in this project. All of the steps and outputs that Joe's talked us through can only become a reality by having the right people engaged in the project. And the role of the Data for Children Collaborative with UNICEF has been to identify, onboard, and manage the diverse teams of people needed to work together in partnership on this project. I'm showing you now a stakeholder map which gives an idea of the depth and breadth of both organisations and individuals within those organisations that we have got working on this project together. The expertise they bring are as wide-ranging as sectoral expertise on adolescence, data analytics skills, data science skills, geospatial analytics skills, as well as things like building an infrastructure that they can all work together on and getting the ethical expertise input onto project design to make sure we're doing the right thing for the right people and having a real impact on adolescents and young people.
Thanks, Alex. I'm Albert King, Chief Data Officer at the Scottish Government. So our collaboration with UNICEF and the University of Edinburgh is all about using the power of data to improve the lives of children. It's about finding new and innovative ways to do that, and doing so through a collaborative that brings together the skills and expertise in data science, policy and research to help solve some of the most challenging problems we face globally. Importantly, delivering actionable insights that make a real difference. So this project is a great example of the collaborative turning that ambition into action. As Sudha and Dr. Blaise explained, there's a real need for these insights to help better target interventions in Côte d'Ivoire and ultimately to help achieve the 2030 SDG goal of ending AIDS. So it's fantastic that the collaborative has been able to assemble such a talented and diverse team to deliver the innovative analytics and use of data that Joe outlined for us. Scotland has some outstanding talent in data science and is an open, connected country seeking to make a positive contribution internationally. I'm delighted that we've been able to support the collaborative to bring together such an important project.
It is really exciting to see such a multidisciplinary team with diverse skill sets coming together to solve a programmatic bottleneck for young people. The first country for this data innovation is Côte d'Ivoire, and we are getting ready for Botswana and Zimbabwe as well. Through this work, we look to strengthen program design and delivery and reach adolescents and young people at risk for HIV more effectively and more efficiently than ever before. Thank you.
While challenges remain in achieving the Sustainable Development Goal of ending AIDS as a public health threat by 2030, there is light on the horizon. The innovations discussed today can help us dramatically improve outcomes among children, adolescents, and young women. Moreover, they help to accomplish UNICEF's mission to identify and address the needs of those at the highest risk. We've come a long way in the fight against HIV, but we have more to do, especially in the wake of COVID. Now more than ever, we must continue to fund the HIV response for children and scale up innovations for both prevention and care. In your decision-making, advocacy, and delivery roles, please join UNICEF as we stand with children and young people in this fight. I want to thank all of our presenters, our funders, and most of all, our implementing partners. The expertise and passion you bring to this issue is deeply inspiring. For those of you watching during our live session, I hope you can stay and participate in our panel discussion immediately following this video. Once again, thank you.
Good morning, good afternoon, colleagues from across the world. It's a pleasure now to be moderating the live question and answer section of this presentation. My name is Dr. Shafiq Isaji, and I work for UNICEF headquarters in New York. Please do type in your questions into the chat, and we will endeavor to answer them in the time that we have available. I'm very pleased to be joined in this panel discussion by Dr. Joseph Crispwell, who's a scientist with the National Scientific Statistical Center for DFID based in Glasgow, as well as Alex Hutchinson, who leads the Data for Children Collaborative out of the University of Edinburgh. We have our colleagues from Malawi, Aaron Mdolo, who works for UNICEF in Malawi, as well as Smilka Delusini, who's the program manager for HIV diagnostics and cervical cancer in UNITAID. And we have from Ghana, Dr. Stephen Aisi Ado from the Ministry of Health's National STI and Prevention Program. Welcome, colleagues. It's great to have you. Over to you.
Thanks, Shafiq. So, as I said during that presentation, we're working with a really broad network of collaborators. So, bringing together UNICEF, we've got the Data Lab in Scotland, the UK and Cote d'Ivoire governments and other partners. So, using that network to understand the range of data sources that are available and how we can access them. And in particular, looking at how they're most useful to particular country contexts. So in this first case study of Cote d'Ivoire. So there's a lot of open data that's available for Cote d'Ivoire, and we want to leverage the understanding of patterns of socioeconomic activity. We're also looking particularly at data that can augment traditional sources, so things like satellite imagery. I think you mentioned there as well, Shafiq, the Facebook data. We're looking at privately owned data like mobile phone, call record data, social media data, and they've got a huge set of information around risk factors for adolescents. So we're looking at establishing agreements with mobile phone operators in Cote d'Ivoire that would provide us with strong measures of population connectivity and mobility, which Joe talked about how that helps the modelling. So as we explore further, we'll be looking at social media data sources like Twitter and Facebook and trying to get summary statistics that relate to HIV risk out of those.
Alex, thank you very, very much. My next question is for our colleague from the Ministry of Health in Ghana. Dr. Steve, you presented some extraordinary data highlighting the successes of the pilot implementation of the family-based index testing initiative, as well as some of the amazing work around the CATS, the community treatment supporters for adolescents. The results that you shared were really remarkable in terms of the linkage to care and the very high levels of retention that you're now seeing in the national program. What steps have been taken in country to try to take some of this learning from implementing these pilot ideas into Ghana's health service? How are you planning to institutionalize these successes? Dr. Steve, over to you.
Right, thank you. Thank you very much, and good afternoon to our audience. Indeed, in January, as of January this year, we have adopted and introduced the index-based family testing routinely in our HMIs. We have a district health management information system, which collects data routinely through the work of service providers. And to make sure that we maximize the benefits of this, and because of the results we saw, we have actually adapted or updated our tools for routine reporting to include family-based index testing, and we're collecting data continuously from that. That is just to ensure that immediately we get the data timely and routinely, and we analyze as we go on to be as a basis for the scale-up.
Fantastic. Thank you, Steve. We look forward to more learning from you as you take this forward. And we're sure that in Ghana will be a fantastic place to try to implement this to scale. I have a question from our chat from Marjorie Mbule from Mothers to Mothers. And this is a question for our colleagues that were talking about multiplex testing for EID. So if I may direct this to Aaron Mdolo from UNICEF Malawi. Aaron, Marjorie would like to ask what role you see for community health workers in driving access to innovations such as point of care and multi-diagnostic testing. What about the role of community in demand generation and how important is this as a key to success, especially during the time of COVID-19? Over to you, Aaron.
All right, thank you so much for that wonderful question. The community health workers are very important in multiplex disease testing because, you know, as this platform they are meant to be used at the point of care where the technical expertise is really limited. So we see the community health workers to be very critical when we're testing to decentralized places like in the communities. So they've got a very important role to play to make sure that the EID is accessible to all who need. In terms of community engagement, yes, that is critical. In fact, I would say the part of community engagement is paramount when you are bringing the multiplex testing to the communities, because they first of all need to know that there's this particular technology and it is accessible, and these are the importance of this technology for us to if we access it. I would say even for those who are now just planning to engage in multiplex testing and on using point of care, the first thing which is paramount is to make sure that the community is well engaged. They're aware of where is this technology and how good is it to the community, and even the using the mothers, PM mothers to tell the community on how important this point of care testing is for HIV exposed children. I think that's very important. In terms of how do we see this working in terms of COVID-19? That's a very nice question as well. At the moment, with the travel restriction, we feel it is very important for the community to own this point of care testing, because it really helps for them to know within their community, without somebody coming from somewhere within their community, they should be able to others and tell them that there's a availability of testing for COVID. That one is very, very important. In fact, the catalytic platform has already been put in place. Now it will be a matter of throwing other diseases on top of it, because the landscape for multiplex testing has already been established. Over.
Thank you so much for that, Aaron. Alex Costa from UNICEF, do you want to chime in on the question of community engagement and the role of community in the rollout of point of care?
Yes, thanks, Shafiq. I'm going to be very brief, time restrictions, but I just compliment what Aaron said by saying that I think the role of civil society organizations and community-based patients should not be underestimated, because you might, with a system in place, with machines, with the supply chain, with equipment maintenance and human resource capacity, but without the engagement of communities, very often those who need to be tested are not aware that the test is available, and doctors are not ordering the test. So in line with understanding, UNICEF has been working in partnership with GMP Plus
and with support from Unity to develop a strategic framework for community engagement in order to generate demand for early infant diagnosis and viral load testing. And that comes with a resource package with a number of templates that the communities can use in order to engage with others and seek funding and sensitize communities in order to do the test. So I just wanted to complement this, both the strategic framework and the resource package will be piloted this quarter in Malawi and Senegal, and we hope to have a finalized product by the end of the year. Over to you. Thank you very much. Thanks, Aaron.
Thank you to both. The next question goes out to Joseph from the DFID Data Science Center in Glasgow. Joseph, your presentation was excellent, and several people have asked questions on the chat. Lino Neves da Silveira is from the Brazilian Ministry of Health, and she was particularly interested in asking about, was particularly interested in asking about the mobile data project and the extent to which you considered data privacy for the users as you think about how to collaborate and link up the data into a larger analytic piece of work. Any thoughts on data privacy in the context of this work? Over to you, Joseph.
Thanks very much, Shafiq. That's a really, really good question, and something that's not just limited to mobile phone data as well. In work where we're dealing with sensitive data around HIV, the patient privacy is absolutely critical. So when it comes to mobile phone data, the best way to deal with sensitivity is by aggregation. So whilst the mobile phone data does record information about individuals' behavior, we're not interested in those individual characteristics, but rather we're interested in how we can aggregate and generate summary statistics that allow us to look at the patterns at a population scale. So how we'll protect individual sensitivity is that we'll actually never use or access data on individuals, but we'll use data that's aggregated at some sort of population scale. So in this case, we'll be interested in how are people from different regions across Côte d'Ivoire communicating with one another and also moving around. And those levels will be aggregated usually at the health department level. So in that way, neither us or anybody that uses our tool will be able to access that individual level information, which will be retained in the secure operators databases.
Great, that's very helpful. Sort of a related question for either you or Alex. I'm not sure which of you would be best suited to answer this, but Winnie Nambazira asked specifically about mobile data coming from rural areas in sub-Saharan Africa. There may be less access to mobile phones and social media, and yet adolescents in those communities are also at risk. How can we get around that issue when we're doing a big data analysis that is perhaps somewhat selective in the types of clients that is reaching out to?
I'm going to let Joe answer this because he referred to representativeness in his presentation, so I'll let Joe take this one.
Thank you, Alex. Joe?
Thanks, Alex. Thanks, Shafiq. So again, a really critical issue that we're addressing during our project is representativeness. So mobile phone data isn't going to capture everybody in the population. Now, access to these sorts of tools, mobile phones, is increasing, but as you say, there are areas of the population that don't have access, and that way, if we're using mobile phone data alone, we might miss particular subsets of the population, and that's obviously going to be really important. So there are a few ways that we can address that. We can combine looking at mobile phone data with looking at the coverage of those operators. So where, for a particular operator, say Orange in Côte d'Ivoire, where do people use those devices? And if we can then overlay that information with the data that we're getting from mobile data, we can recognize that there might be areas of Côte d'Ivoire where we're lacking in data, and we can think about how we can address that. And the other method that we'll use is overlaying with a range of other data sets that potentially capture information about those populations that might be missed by the mobile phone data. So hopefully by having this sort of multi-pronged approach where we're drawing upon a range of different data sources, we'll be able to try and address this representativeness issue, which is absolutely critical for our tool to be useful on the ground.
Joseph, thank you very much for that very detailed answer. It was very helpful. I'll come back to you with a question around some of the technologies that are being utilized in the work that you're hoping to roll out. But my next question goes to our colleagues Aaron and Alex working on the Point of Care project. The challenges that you described, Aaron, around late access to diagnosis for infant diagnosis and relatively low male involvement as a hindrance to uptaking that kind of technology are, I think, important to reflect on. Have you thought about how, in the context of your work, you could do a better job of supporting the involvement of men in the rollout of Point of Care? Aaron, over to you.
Yeah, that's a nice question as well. Yes, we have thought of using MER to advocate for the point of care testing. In fact, looking back, we saw that for male to be involved, they should be able to see that the technology is accessible and there's indeed change in terms of the results turnaround time. By using the mentor mothers and by using the mentor mothers within the communities to engage people with the exposed children to come and do the testing. I think that one was one way of trying to bring the families together, using the male dominance in the household to make sure they advocate for the testing of the children and they are getting results as quick as possible. Because first of all, for male to be really involved, they needed to really understand why is it important for them to be involved in this case. Though we did not have the direct, I would say the direct intervention towards male in this case, but the use of the mentor mothers, I think, somehow contributed to the involvement of male to EID testing. I think, unless if Alex have something to add on that one, but that's what I can say at the moment. Thank you.
Aaron, thank you very much. In the interest of time, I'm going to move on to one last question, which I will ask of Sudha, my colleague from UNICEF, who is leading the work on our side with the Data for Children collaboration in Côte d'Ivoire. Sudha, on the presentation that we shared, we didn't see any voices of young women talking about the issues that are relevant to them. And I do understand that this is still in the planning and development phase. But I wanted to observe the very high proportion of HIV infections that are occurring among young women in Côte d'Ivoire. Something like 83% according to Dr. Bies. So what thoughts and considerations have been given to involving the young women as part of the Data for Children collaborative work?
Thanks, Shafiq. So the first thing is, this is one side of the data piece that you're saying. There are multiple parallel processes of engagement that are happening. Côte d'Ivoire, UNICEF has a partnership with multiple sectors in the government and has several reporters who are on ground, and several of them are young women. the most important stakeholders in this project. So one of the first pieces of discussions were with the young people, including young women, 15 to 24 in Cote d'Ivoire, through a set of you reporters in terms of what is the issue, what is the need, and how do we want to move forward. So, the framing of the issue actually started with the young people on the ground to actually shape what are the challenges of HIV risk and new infections. The second one is in terms of, Joe talked about the open street maps and some of the health facilities and adolescent services mapping that are available across the different health departments that are there. So young people have been extensively involved or have led the process of service mapping across these different areas, and they would be part of this whole design and delivery piece as all these different parts start coming together. So they are the core. If you look at Alexis stakeholder map, the first ring is young people themselves. So it's at the heart of the design and delivery, and young people are involved in this whole process of framing the issue, what they want to, what we need to look at in Cote d'Ivoire and how we want to move forward. Thank you. Back to you.
Thank you very much for that response. It's great to see the active engagement and involvement of young people, especially young women, in this work. I think that'll be an essential underpinning to its success. Colleagues, we're out of time. The hour seems to have fled by. And unfortunately, we have to close this session because of additional sessions that are coming. But I wanted to thank all of you for attending, all of our speakers for their fantastic presentations, and also a huge shout out to all of you who are engaged on this type of innovation. As our executive director said, innovation lies at the heart of our programming, and we have so much to learn and adapt to as the world around us changes and shifts with the HIV epidemic. So thank you very, very much again, and please enjoy the rest of the conference.
Thank you.